Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, Hee Hee. Now let's get to the good stuff. Sarah, welcome to the show.
Hello.
Hi, I'm so excited to A, see you again, and B, have you on the show because when we were in Nashville, you were like this deep wealth of knowledge when it came to epidurals, and everything you said was like, oh my God, yeah, people do need to know that in order to make a decision. And oh yeah, it would be really helpful if people knew that going into this decision. And so thank you for being here. And also I'm super stoked to share your wisdom with our community and our listeners. And I think before we get really into the nitty gritty and like, how do you make the decision of whether an epidural is right for you? We should really start with what is the epidural? And so can you explain to us the very basics of what an epidural is? Is there something stuck in your back? Does it come out? Are you going to feel it? How long does it last? What's the kind of basics of it? And then we can get into kind of the deeper stuff to determine if it's right for us or not.
Sure. Yeah. The first thing that I wish everybody knew about epidurals, and that I've covered a lot on my platform, is that it is not a needle that stays in your back. That is the number one thing that is a misconception that scares people away from epidurals, and usually is like the final roadblock if they were considering it, but they're just like, oh, I don't know if I don't want a needle in my back. It is not a needle that stays in your back if that's something you're concerned about. What actually happens is there is a tiny tube called a catheter. It's almost like a little straw, and it's really flexible. It's made out of like a synthetic material, just so tiny. That gets placed in a lower area of your spine it's a lumbar space. So it's between two vertebrae. That gets placed between those two vertebrae in the lower area of your spine. And what happens is once they access that area, that tube it's very long, and then it is connected to a pump on the machine next to your bed. And that pump has a medication. It's usually a combination of like a narcotic and a numbing agent. Usually it's something called bupivacaine. And they're going to administer a very small, low dose of this pain medication from the pump through that tube into that lower area in your back. It's going to bathe the nerve in your lower back and your spine with that pain medication, and it ends up removing pain and most of the time some level of sensation from like the mid to upper abdomen, like all the way down to your feet. There are varying levels of how dense that epidural covers, how numb you feel, how much sensation you have or don't have. It depends on the person, the placement, how much medication you're being given. But the goal is for the pain to be removed, and we just feel like maybe pressure or tightening and have a little like level of movement and mobility in our legs. The tube in and of itself, you're not going to feel it once it's in place. They tape it up really good. And like I said, it's in that lower back. And usually when they tape it up good in the lower back, it's taped from the lower back all the way up to the shoulder. I mean, like a good 1.5 foot of tape, so that you can still like, with me, if somebody like me is your nurse, I can still put you in like hands and knees and use birthing balls and do all kinds of gymnastics in the bed with you. And we don't need to worry about dislodging that epidural. And there is no needle in your back. But the reason that sort of myth exists is because when they place the epidural in, when they place that catheter in, they use a needle with the epidural catheter resting on top of it to access that space. They obviously need to puncture the skin, get into that lower space in your spine. Once they access that epidural space, the needle is taken out, and then that little catheter, that tiny tube, stays in place. We tape it all up all the way up to your shoulder, and like, you are golden, good to go. If you're familiar with an IV, it's very similar to an IV. It's the same kind of a thing where it's a needle and a tube. You get into where we want to go, the needle comes out, tube stays behind.
Nice. I love it. Okay, I think that gave us such a good visualization of what people can expect because, like you, I do run into a lot of people who think that a needle is left in your back. And I explain it very much like you do. And I say, no, they will have it taped completely up. You won't even notice it. And it's not a problem. But if we need to move it, we can. If we need to kind of mess with it, and we'll dive into that later. But where I want to go immediately from there is, in order to get your epidural placed, what can we expect? We need to sit on the edge of the bed. We need to be able to be still in between contractions. We need to have ourselves hunched over, curled over into a C position. Can you explain to us what we're doing and why?
Absolutely. And that's a good question. A lot of people don't talk about what it looks like once you've asked for the epidural.
Mhm.
You do in your labor, and then if you're like, hey, I am ready for my epidural, there's a little bit of time between when you've requested it and then when they come in to place it, it's placed, you're medicated, you're getting comfy, and you have that beautiful epidural nap afterward. In that time, what happens is you say, give me my epidural. Like we talked about, if it's working well, you're not going to have a lot of sensation in your feet, right? So getting up out of your bed, walking to the bathroom, at least with epidurals in America, is not very common. We find other ways for you to use the bathroom when the epidural is in place. So for my patients, the first thing we do when they say, I want my epidural, we do one final bathroom trip to have a nice empty bladder before we are in the bed for a little bit longer. And then a lot of times, and I let my patients know this, if you don't have any IV fluids started at that point in time, if you've just been doing your thing and you've been free, loosey goosey, a lot of times at that point, your nurse may connect you to IV fluids. And she may even do something called running a bolus, which means a bolus, in any medical term whatsoever, is giving you a whole lot of something really fast at once. So she may give you a lot of fluid really fast. And the goal for that is to raise your blood pressure a little bit higher than it normally would be, so that we would offset a potential side effect of your epidural, which is really lowering your blood pressure and making it uncomfortable for you or unsafe for your baby. So we would help you to the bathroom one more time. Your nurse will probably connect you to IV fluids if they're not already going. She'll probably run a bolus, what we call it. You may feel a little cold through your IV. And then once all that's going, then you're going to have a lot of stuff put on you. They're going to put on a blood pressure cuff. She's going to probably put a little sticker on your finger that measures your oxygen and your heart rate. That's called a pulse ox. And then at that point, we would sit you onto the bed. Where I work, it's usually on the side of the bed, and you'll be like face to face with your nurse, just looking square on. And then we scoot you back really far in the bed, but still sideways on the bed. The anesthesiologist will eventually come around to the other side, like where your back is. And then we need you to like assume the position, right? So because it's in that lower spine and we need to get into between these two vertebrae, if you're sitting up nice and straight, if you think about the spine, those vertebrae are going to be compressed nice and straight, closer together. When we hunch forward and do like that Halloween angry cat thing or a shrimp, that is going to open up that lower lumbar space. And that's the position we're looking for. It's going to make it much easier for the anesthesiologist or the CRNA to get into that area of your spine. That's really the only thing that the patient can do themselves to facilitate the process, is just holding that good position, which is a really hard position when you're pregnant and you've got a big belly. You'll just be opening up that lower spine, curling and hunching, terrible posture forward. If you are contracting painfully, it can be a little tricky, but the good news is you can ask them to stop and take a break if you need while you're contracting, or if you're still able to hold that position, they can still keep going. And basically, as long as you're not just like climbing all over the bed, writhing and being like way all over the place mobile, movement is okay. It's not going to throw everything off. You don't need to be so scared that the tiniest breath at the wrong time is going to cause a huge hiccup in the procedure. We do this all the time with people who with a varying level of cooperation, and it goes really well most of the time.
That is so
Um,
good to hear because I think that just the fact that we are going into our spine and people recognize and realize how sensitive our spines are, that's where a lot of the fear comes in. Later in the episode, we'll talk about what can place an epidural. But I'm so appreciative that you brought that up because I think that's where so much of the fear. I hear
mhm.
everybody say, I don't want to be paralyzed. And
Yeah.
I too don't want you to be paralyzed. And I also understand the fear. Like before I understood epidurals, I totally would have thought that was a real thing. And anytime you go in the spine, obviously you have a risk that something goes wrong. But with an epidural placement, it's so little. The risk of something seriously going wrong or paralyzation is
Mm.
really low.
Yeah, yeah, it is. It's so small. In fact, like any like hiccups or complications I see with epidural, it is not my patient moved and got
Mm,
paralyzed because it poked the wrong spot. It's nothing like that. The common complications, which I'm sure we'll talk about later, are very different ones that most people wouldn't have even don't even know or anything to consider or worry about. But the biggest number one fear, is it a needle in my back? Am I gonna poke or ruin my nerves? Am I gonna be paralyzed if I don't sit perfectly still? That's
yeah.
like quite a burden to hold on yourself when you're in labor and contracting, that I'm gonna paralyze myself if I squirm or move the wrong way. I wish I could release everybody of that burden, that it just takes a little bit of cooperation, a little bit of holding that position when you can, and we're gonna be fine. You feel free to let them know that I'm having a contraction. I may need to adjust a little bit, and we really can accommodate that. And if they're in a place where they're like, actually, can you just try to hold still for 2 more seconds, they give you that heads up. And it is, again, I think it's important to keep in mind that like countless people have epidurals and do this every day for decades and decades. And again, there are varying levels of cooperation from people. Not everybody is the perfectly still patient. So if this were something to worry about, that you move the wrong way, you're going to get paralyzed, we would see it a lot more, and it probably wouldn't be on the table as an option. So
Totally.
it is okay to move a little bit. Just please release yourself of that burden. Okay.
Yeah. I
So
think that's so helpful to hear. Okay, but it leads me to my next question of is there a time that's too late? I know ACOG says you can get it as long as you can sit still and we can place it in your experience. Is there a resistant to place it after a certain period, or does it ring true that no, as long as you want it and you are able to sit still enough for placement, then we can give it to you?
it's another really good question. Another thing I wish like a PSA I could put out there, that there is no magic dilation or number to get your epidural or to no longer get an epidural. It
Yeah.
really is going to be situation and hospital dependent or provider dependent.
Mm,
And what I mean by that is there will be facilities out there that have a rule, a policy in place that we cannot give an epidural past whatever dilation. And it's not because something magical happens at 9 centimeters or anything. It's just for some reason that's a policy they have in place that works for their facility, that's sustainable for them. But it truly for them comes down to a policy. Most of the time these days, if you are able to safely sit still for the procedure, like we talked about, and as long as the baby is not is not like making their grand entrance sometime before that epidural is being placed, you can get an epidural. I have absolutely seen epidurals be placed 7, 8, 9, 10 centimeters.
same.
I've seen them placed at one. So yeah, that's another thing. You don't need to reach or avoid a certain level of dilation for your epidural. It really is, if you can safely sit still, and if the baby is not coming and you're going to be able to even see the effects of the epidural, you can get it.
Yeah.
But again, since it is facility dependent, you'll need to talk to your provider. And then where I work, we do a lot of high risk deliveries. And there are some situations where we do need the epidural in maybe a little earlier or later, depending on the situation and their medical complications that come up. So again, it really needs to be something you talk to your provider about, to see what their policy is, and to see if you're one of these very rare little outliers where we have to have more of us have things planned a little differently than for most people. But for the majority of people out there, no, sit still, baby's not coming. That's the only thing we need.
Nice. Okay. And in terms of being hospital policy, we always hear hospital policy is not law. But in this case, what would happen is you actually would not find a provider who was willing to place an epidural after whatever that policy says, right?
Potentially. Yeah. It is so true. And I say that a lot to my patients. Hospital policies, hospitals in and of themselves, it's not prison. You're not
Yeah.
prisoners. It is not law. But if you're going to accept or decline certain things and you've been well educated, you're making this decision, this knowledge-based decision, there with the hospital, if they have policies surrounding the decisions you're making, they also have they've got to operate within those policies. Just like maybe we can't give certain medications without fetal monitoring, you can accept or decline those meds as long as you know that they can't give it unless you say yes, I'm okay with fetal monitoring. Same with an epidural, that even though we know, because people are doing it all the time in these hospitals like mine, you can be 10 centimeters and get your epidural if baby's not crowning and you're able to hold still a little bit. That's a fact. We do that. But if that hospital does not support that, if that is not their policy, we can't force them to act in that. And it may also, it's a lot of times it's safety measure for them. It may be that like they don't have the resources. If something were to go south, they may not have enough staff. They may not have enough anesthesiologists or CRNAs available. Maybe there's only one for the entire hospital. And they're like, this is my only shot to give you an epidural. If you ask for it in 4 hours, I have a case. It sounds, I wish it weren't that way, but that's how some hospitals operate, which is why it's good to vet your hospital, your providers, ask these questions.
Sure. In your prenatals is what Sarah means, you guys,
Exactly.
not like
Yes.
in labor. We want to be having these conversations beforehand so
Before.
that if you have the option, if you decide to, that you can change providers or hospitals again,
Yes.
if that's an option for you.
Yes.
Yeah.
Yeah, definitely.
Okay, so along those same lines, I always get asked the question, all right, so if I want to get an epidural, then I have to get the IV, but not having IV in labor is a hot topic right now in the
Yeah.
birth space. And my answer is always, yeah, most likely, but talk to your doctor. Would you say, from a medical standpoint, if you were not okay with getting an IV, you probably would not find a provider that was okay giving you an epidural?
So I would say from my experience that it'd be very hard to imagine a scenario where a facility would move forward with epidural anesthesia and not have IV access. And a lot of that is because not just the safety measures of, because we had already touched upon one of the side effects of an epidural could be dropping your blood pressure really low and really fast. And a way we would help remedy that is doing IV medications, IV fluids, things like that. Yeah. But also there may be certain medications that complement the epidural that we give through the IV. You, like I said, they're probably going to want to give you a bolus of fluid before you get your epidural. Now, I'm sure it is physically possible to have an epidural in place without an IV. I've seen it because their IVs have come out during labor and they have the epidural in place. It's physically possible. Is it the safest way? No. You may find somebody who is okay, but then at the tiniest little change, we need to pop an IV in. I'm sure there's somebody out there in the country who's okay, let's put the epidural in without your IV, but at the tiniest little sign of an issue, we've got to get an IV in. Maybe they exist, but this isn't like my opinion on the matter. I would love to avoid IVs if we didn't have to. But I would just put out the expectation that pretty much any provider is going to need an IV in place at the time of or right prior to getting your epidural in.
That's what I always tell people too, is you're just probably not going to find a doctor that's okay with it, but it never hurts to ask. Also, just make sure that you do understand what the real risks are with declining it. Doesn't make it wrong or good or bad, wrong or right. It just means just make sure that you know what you are getting into. Okay, next question. Do partners get to stay? In my experience, it's very dependent on the anesthesiologist. What do you say about that? What do you most commonly see, and what can people expect if their partners don't get to stay? So and I guess get to stay. Can you explain both?
Absolutely. It's, again, good questions. Yeah, you are full of good questions. So again, this is really hospital dependent. And then depending on the hospital, it's going to be provider dependent or facility. I don't think birth centers do epidurals, but
some of them do.
I think they exist. But yeah, it's going to be facility dependent. So where I work, There's pretty much across the board with whether they like it or not. We have a policy that like they can have one visitor with present with them during epidural placement. Now, if this became like an emergency, that is the only time when we don't have a visitor present for pretty much every blessed thing we do from start to finish.
Mm-hmm.
What would happen, what that would look like if your visitor is able to stay with you, your support person is you said, I want my epidural. Nurse is great. I'm going to send a message to the anesthesiologist. Let's go pee. Let's empty your bladder real quick. Here's those fluids. Is it okay if I give them to you? We sit up in the bed. Here's a sticker on your finger. Here's a blood pressure cuff. Let's curl in that position. Anesthesia walks in with this ginormous, big, like cart full of
Yeah.
stuff. They like park the cart on the other side of the bed and they're like, all right. And they clean up your back. So on the front of the bed where you're facing almost nose to nose with your nurse, you're going to have a nurse there. And where I work, we do something called a timeout where we say, hey, we do want this procedure. You understand what it means. You signed and spoke with your provider about the consent. This is the right patient. Yeah. Okay, cool. Let's move forward. Your partner is there for all of that. They've not left the room at any point in time, right from when you said, I want my epidural. They've not left the room. And if they did, it wasn't because I kicked them out. Where I work, the one rule we have about that though is for them to be seated, because if they were to catch a glimpse and they were a little bit like woozy at the sight of whatever's going on back there, we don't want them fainting. So we have them seated with you and they're usually like right there. You're sitting on the side of the bed, your legs are dangled over or crisscrossed, and they're holding your hand, rubbing your legs. I usually am right there. I worry about charting later, so I'm usually helping you through it because you're still uncomfortable. You ask for it because you're in pain. So that pain doesn't stop until the epidural is taking effect. We're still breathing through contractions, and then you just got the nurse and your partner on either side of you. I've also seen where anesthesiologists or CRNAs are very like relaxed about things and they're not going to force the partner to be seated or anything. Sometimes they'll be like, you can peek if you want, as long as we're able to keep it sterile. But that's typically what I've seen in my experience. But there will be facilities that may say no visitors whatsoever. And if that's the case and your visitor is asked to leave and it's just you and the staff, hopefully you have an emotionally, physically supportive nurse who can help you through that. And what that looks like is going to vary from one person to the next, depending on how much pain they're in, how they're coping with that pain, how much emotional and physical support they're requiring when they ask for their epidural. So I've had patients that we're just chatting and breezing through it. And then other patients that have a lot of anxiety about it or a lot of pain. And they've literally hung on my shoulders, like forehead to forehead with me to get through the contractions. So whatever level of support that you need, I would hope everybody feels comfortable asking for it. They may not feel comfortable asking, but definitely they should be getting that from the staff, especially if your support person is asked to leave.
Yeah. Okay. And what about if this person is just not ever allowed in there? So that's something I have seen is that once you get the or once you ask for the epidural, when you head to get your epidural or when the anesthesiologist comes in, they will ask the partner and usually the doula to leave and we go to the waiting room. It should all be the same, just minus your partner in the room, right? Everything that you
Uh-huh.
just described should be the exact same.
100% the same. So you ask for the epidural, anesthesia shows up, regardless of who is and is not in the room, should be the same process. You pee, if you agree to it, get the fluids, sticker on your finger, blood pressure cuff, hunched over. Someone, hopefully your nurse is able to help you through
Mm-hmm.
any anxiety or pain that you're experiencing. Or maybe you don't need that. Maybe it's uncomfortable for you to have them and you just are like, just you sit over there and chart girly. Like I'm going to do my thing in my own world, whatever you want. But yeah, that's typically what it looks like. You're just hanging on to that position while they're placing that epidural in the back. We do that little timeout thing where we say, this is your name, your birthday, all of that stuff is still going to happen with or without the partner. The only difference where I work is if the partner is there, they're just along for the ride. They're just sitting next to you,
Sure.
holding your hand, helping you through it. The same events are taking place regardless.
Sure.
It's really unfortunate though that like where you are, they excuse the partner. I can't speak for all the facilities, but we do high risk.
Yeah.
I've seen pretty much all shades of birth, and
Yeah.
I just can't imagine why. I just can't think of a good reason why they need to be excused unless they've been causing issues with the staff or they are not supportive for the patient. The patient wants them out, but
Yeah.
I don't know.
Yeah. In our experience, it really typically we get told by the nurse, okay, like that's totally fine. And then she'll turn to us and typically say, when everything gets set up, we'll just have you guys go out into the waiting room and then we'll have you back in. It typically takes 45 to 60 minutes. So within an hour,
Mm-hmm.
we're usually reunited. And sometimes we always will ask. So every time we will push back on that. Sometimes the nurse will say, you're going to have to ask the anesthesiologist. And sometimes the
Mm-hmm.
anesthesiologist will say, yep, you know what? Usually they ask if we've been in an epidural before, and we all have. And so we say yes. And then they ask the partner, are you comfortable with needles? And I'm going to have you sit and all that. And then they do. Typically, either we're both standing or they're sitting and we're standing behind the partner, or we both get to both get asked to leave. So
Yeah.
we find that it's either all or nothing. They never really say your doula has to go and your partner can stay. It's usually,
Mm-hmm.
yep, you can both stay, or no, you have to both go. And it's 50-50 is usually what we teach our people because in our experience, you really don't ever know.
You never
Um,
know. Yeah.
yeah, you never know. It's always much more helpful when you have your partner. There's just something
Mm-hmm.
about having your partner there.
Yeah.
I agree with you too. I can't really think of a good reason, but also I don't know all the reasons
I,
of everything.
yeah, I only work where I work
Yeah.
and it works where I work. So I
Mm-hmm.
don't know I don't know the resources other facilities have. And there's going to be hospitals out
Sure.
there, like rural hospitals that have very little resources. So whatever they need to do to keep things safe, I think makes sense. But I think probably the biggest concerns that we would have would be making sure we can keep it clean and sterile.
Mm-hmm.
And then the other one, making sure that the partner isn't going to feel woozy and pass out, really. So we don't have another patient to
Sure.
worry
I was
about.
going to say, then you have two patients.
Yeah, but like beyond that, I can't really think of it. So yeah, it's just, again, another question to add on your list and ask at an
Yeah.
appointment.
Yeah. Okay. So you had mentioned a little timeout in your verse spaces,
Yeah.
and I want to dig into that because a lot of times when people pivot, and this is where doula support, in my opinion, is so crucial and can be like a game changer in the birth space. A lot of times when you're pivoting to something in birth, it doesn't always get the pause that it deserves to make
Hmm.
sure that person really understands what's going on. They have been able to ask their questions. You've really talked about the risk and benefits. And in my experience, again, it's very provider dependent. Sometimes we
Hmm.
have a nurse or a doctor who will come and sit down and have true good discussion and almost like a timeout, like what you talked about.
Hmm.
And then sometimes, Sarah, they're literally shoving a clipboard with a piece of paper in your face and saying, like, all right, we'll sign this, hurry, hurry, so I can get your fluids, I can get you
Oh
this.
gosh.
And our team is very used to speaking up in those moments and saying, hang on, do you have any questions? This is a consent form. Do you have
Hmm.
any questions on what's included? Do you have any questions about the things that we talked about in our prenatals for your nurse? But for people who don't have a doula, or maybe they don't know what questions to ask, can you tell us a little bit more about that timeout, what it is for, and how it benefits your patients? Because that informed consent is super, super
Hmm.
important.
Absolutely. Another great thing to bring up. So, a consent form and the timeout are two totally separate things. And where I work, you can, when we sign a consent form, it's good for 30 days, right?
Wow.
So, we can bring up consent for like blood products or an epidural or anesthesia, surgery. We can even bring those up in a prenatal appointment when you're not in pain, things are not crazy and dire, and you're not exhausted and sleep deprived. And we can go over everything, talk about everything, answer all your questions. You can mull it over and sign it, and it's good. And then when you just pop in the hospital and show up in labor weeks later, potentially, it is signed. That would be ideal, right? And then sometimes that doesn't happen. A lot of times it doesn't happen.
Yeah.
So whenever our patients come in and are admitted, whether it's an induction, whether we don't know if they're in labor, they are in labor, maybe they're 3 centimeters, who even knows? If there's an opportunity for it, basically baby is not coming right away, then pretty much that first hour of being admitted, they go over the consents because we know things are only going to, not in a bad way, but escalate. It's only going
Sure.
to be more emotionally draining or physically exhausting. So we want to do that when you have more reserve and that you can absorb that stuff. Consent forms should not be signed in
Like
without you
under
really,
duress.
yeah, to hurry, let's go.
Yeah.
And now
Yeah.
sometimes it just needs to happen, but then that's why there are certain laws about verbal consent in an emergency where we have 1 minute to decide something, and everybody's doing the best they can do.
Sure.
But doing an actual consent form does take time. The provider should be going over it with you, should be going over numbers, risks, benefits. What questions do you have?
Sure.
Okay, great. That is what consent really is. Then they say, do you have any questions? You feel good about this? Okay, great. Do you understand it? Yes. All right. You go ahead and sign it. Where I work, for some things, you even have to have a witness when they do
Wow.
these consent forms.
Like what?
I can't even think off the top of my head, but they'll pull us in and say, I need somebody else to witness that this consent
Wow.
happened. So that should have happened long before somebody walks in and they get the epidural. It's if we can avoid them happening at the same time, that would be ideal. I would say 98% of the time, the consent has happened in a calmer, more mentally reasonable space. Then down the line, if we do end up moving forward with a C-section or an epidural or whatever it may be, the consent was signed, and then we do this timeout. So then bringing us to the timeout, that is one of the very first questions. We have a timeout. It's a policy where I work before any procedure. And where we work, an epidural is considered a procedure. We treat it like we would treat surgery in some aspect. We don't treat it like an IV where you can just plop it in at any, like in a 5 minutes, it's not a big deal. I have my patient all set to go, we're ready to go, right about to start the procedure, and we do, okay, timeout. We have a list of questions we go through, and one of the very first questions is, are the consents signed and are they on the chart? We don't want to move forward with a procedure that the patient has not consented to. And that's another reason why we want to separate these things, because informed consent, it's hard to get informed consent when you're, under duress like that.
Yeah.
So ideally, someone has sat down and explained the best that they can what this procedure is, gone over the risks and the benefits. And if you ask any alternatives, what are other pain management options? Is this the only way I can manage my pain? Are there other things? Okay, great. That's all part of informed consent. We do the timeout to make sure that we don't make mistakes, like they never signed a consent form, to make sure this is the right patient, that somebody in room 15 paged for an epidural and we're actually in room 20. We want to make sure that the patient verbally has agreed to it one more time, because maybe they did come in and say, I didn't really want an epidural, and then they change. Totally fine to change your mind. Nobody thinks that you're wishy-washy and lame and that you failed, but we want to make sure that you are like, oh yeah, I definitely want this. Yes, I know I said I wasn't going to get one. But I've changed my mind and I'm totally at peace with that. We need to hear that from your mouth. These are all good practices to have in place. I'd say in the next 15 years or so, I would expect every hospital to have timeouts, to have all of that stuff in place before we do epidurals. But it's not necessarily a requirement everywhere at this point in time. But that is what you should be expecting with consent. And that's why these timeouts exist, because we're all humans, we're people, and mistakes have and do happen.
Totally. Yeah, everyone's human. And also, that's just like part of having a job. You make mistakes in your job. You're just not a nurse, right? Everyone makes mistakes in their job. They just don't happen to be a nurse. And so the
mistakes are
aren't severe.
much higher. Yes. So
exactly.
we do not want to make a mistake here. So we do this. We do the timeout. We take a minute. We take a beat. We double check everything with the whole team. We say it out loud with the patient there. And then we move forward to make sure we're on the same page. And it's good. We've caught errors that way.
Yeah. Oh, I bet. Yeah. Oh my gosh, that's amazing. You mentioned like in the next 15 years. I'm looking forward to it. I hope so.
We better.
I
If
love
not,
this.
they need to get with the time.
Seriously. Okay, so I've always been taught that in an epidural, the mixture of medications can vary. Not using necessarily different medications, but which, I guess, mixture or combination of these different drugs is kind of based on anesthesiology. What do you know about that?
I know what I know where I have been working, and I know that it can vary, but typically what you're going to see where I work in America is some blend of a narcotic and like a numbing agent. This is a good thing just to keep in mind for any, like just in medicine in general. Numbing agents end in the like in ane, AINE. So like lidocaine, bupivacaine. If it has that ane at the end of it, it's a numbing agent. And something that numbs or removes sensation is not exactly working the same way as a narcotic, which is a pain reliever. So you can take a Tylenol and it may relieve pain, but it isn't going to be like a numbing agent like lidocaine. So when we're doing epidurals, Like we said, we access that lower lumbar space. We tape it up really good. We have that tube. Now all we need to do is put something in it, bathe that nerve in something to shut off the pain receptors and be like, look, we know we're in labor. We know we're in pain. We don't want to talk about it anymore. Okay. So then we have a blend of medication. And where I work, it's usually something called bupivacaine, which is a mix of this narcotic called fentanyl. And it's a very small, safe dose of fentanyl. And it's blended with a numbing agent, one of these ANEs, and you get that bupivacaine. The way it's mixed up where I work is pretty much a standard dose that we give to all patients, the way it's mixed. And then when we go to give it to the patient, the anesthesiologist comes up with a dose that seems appropriate for the patient's pain tolerance history, maybe what their BMI is. Different BMIs require different levels of different doses of pain. So then they're going to come up with something. They're going to tell us, give them this dose through the pump. And then there are some people, it's not as frequent, but there will be some people who are like, they need a different blend, maybe a lighter, lower dose, but that would need to be mixed up with the pharmacy because it is like a very high stakes medication to mix up. These numbing and narcotics blended together. It is mixed by a pharmacist on another part of the hospital who brings it up to us. If my patient is like, maybe they are recovering from substance abuse,
Sure.
recovered, and now we're in like remission from substance abuse, and they're concerned about using narcotics, but they want the epidural, which I've had this happen before. They may request like a lower dose or different doses so that they get really concerned that they're going to get back on that track. Then that's something that we would talk about with anesthesia, the OB, and then they would put in different doses in the computer. The pharmacy would mix up a different dose, all of that. So it definitely can vary and does vary from one person to the next. But what you're going to pretty much see is a narcotic and a numbing agent blended together going into that epidural.
And how long after the placement can you expect to see the effects of it and feel some relief from your contractions?
So another great question. So usually what I tell my patients from when they've asked for the epidural to when they're like all the way on the other side of things, like not feeling pain with the contraction, they could sleep. That's going to vary again, depending on the facility, how difficult it was to place, how easy it was to place. But I usually say give that an hour. So if you ask for the epidural, I would at 4 p.m. I'd expect by 5 p.m. you're laying down in bed, chilling, and you're like, I'm feeling pretty good. Now, from when they've placed it to when you're starting to feel relief, right? We've done all the setup, we've gotten in the bathroom, did all the things. Now they put it in. When are you going to start feeling better? That really should be happening 10 minutes maybe. What we start doing is they place it and then they usually will test out to make sure that it's in the right spot, that we've accessed where we need to access. And when we've confirmed that, then we lay you down on the bed again. And what you'll start to notice is the contractions start feeling shorter. So maybe your contraction, you felt every minute and a half of that contraction, a 10 out of 10. Now we're laying down, they've started medicating it through the epidural, and you are maybe only feeling like 30 seconds of it, but it's still pretty intense. It's still like an 8, but now it's only 30 seconds. The next contraction, you feel 10 seconds of it, and it's a 4 out of 10. Then the next one, you're like, oh, it's like a 2, and it feels really short. That's typically how I see this play out. They feel shorter.
Does that mean that your contractions are shorter or you're just
No.
feeling less?
You're feeling less, and they feel Perfect. Your brain is perceiving it as shorter, but they are just as long. So your contractions are still going to be however long, however often, theoretically, but they just are in your brain going to feel shorter and feel less painful. And then eventually on the other side of it, they should just feel like tightness, pressure, things like that. It shouldn't feel really painful.
Yeah. Okay. And for people who have like the windows or the pockets where the epidural doesn't cover, I'd love to talk about our options there. What I typically tell people is they can always come back and give you more medication. You have your PCA that you could try and give yourself medication yourself. That's a patient controlled administration. Is that what that is? Yeah. It's a button, you guys, that it literally just looks like what they hold on Jeopardy, actually. Like it's a long thing and it has a button at the top and you press it and give yourself medication. We can have the anesthesiologist come back and wiggle it and see if they can mess around with it a little bit. But then our last resort is kind of to replace it. Is that also what are there any other options that we might have for people who don't have that full coverage? And also, how often do you see that happening?
So, I mean, so first of all, how often do I see it happening? I wouldn't say straight up it's often, but I wouldn't say it's not common altogether. I'd say
Yeah.
it's hard to throw a number out there for me personally, but I'd say like the majority of my patients experience the relief that they're looking for and stay pretty darn comfortable. But I would still say most of my patients at some point in time, they're being like, oh, I'm starting to not feel great. And we have to do a little bit of tweaking, but
Sure.
not a lot. So I would expect that you should have good, adequate pain relief. You should feel a lot better. I would expect that statistically, it's likely that it's working well for you, but also that there's going to be a little bit of tweaking and adjustments, even if it has
Mm.
been perfect and great. A little bit, whether that's changing your position or something. I it's again, it's not uncommon that my patient, the epidural in and of itself needs to be tweaked, that we need to give a higher dose of medication, things like that. How things will play out for me in where I work and for the most of the people I take care of. If they're one of those unlucky ones who maybe it started working, it was in a great spot, and then later on they're like, this is really uncomfortable again. Like I'm breathing through my contractions. This is painful. What I do as the nurse is the first thing I'm going to do is change your position, which sounds crazy and silly. And that's because something people really don't know about epidurals is they're greatly affected by gravity. An IV, if you put an IV in and we give you fluids, it's going into like your vasculature, which is just your whole body, all over your body. You're getting whatever medicine or fluid. An epidural, we are bathing that nerve in a medication to shut off the pain receptors, numb things out. It is not going through your whole body. Your whole body is not going to be numb. So then if we turn you on your left side and you hang out on your left side and for a nice long epidural nap for an hour or two, then that medication literally is going to settle and distribute onto the side that you're laying on by gravity. So then you might notice that like the top of your tummy that's facing up starts to feel painful. And so that's why one of the first things I do as a nurse is I'll just flip you to the other side. We change positions and then let the medication work its way down to the other side of your body. That's another reason why for the labor nurses out there, the staff, it's important to be keeping our patients moving a lot through labor for 1.5 million reasons. That's one of many. And then if we've done that, we've done a lot of position changes, and I'm just like, man, we really should have expected relief by now. You also have your PCA button that we talked about. Like it looks like a Jeopardy button. It's connected to the pain pump. We have the medication pump programmed so that it is physically impossible for you to over medicate yourself or click the button too many times and overdose. We have it locked off at these ranges. But if you start to feel, we've done these position changes, and man, I still feel a little sore. You click the button and it's going to give you an extra little, like a little whiff of it to cover whatever the epidural is not taking care of. We call that breakthrough pain, right? It's breaking through what our continuous normal pain management has been doing. So let's say I've done that. I've moved you side to side. You've pushed your button. I like to have my patient do the button a couple of times in a row. And then if that's not working, that's when I bring in my anesthesiologist or my CRNA, because this is another thing to keep in mind as the nurse. I'm checking to make sure that the epidural is still in place, that it didn't get yanked out, which is extremely uncommon. Let's just be smart and check the obvious things, making sure that all of my little ports, all my tubing is all connected. It's not leaking anywhere, nothing obvious, no mechanical issue. I brought my anesthesiologist, CRNA, in now. We've ruled out the epidural is working. It's in the right place. You've done your meds. We've moved you back and forth. They'll come in and then they will usually give you an extra, like an anesthesiologist oomph of medication that you can't give yourself. And usually that's going to do the trick. If that doesn't work, they come in and try again. And then if that doesn't work, that after all of this, that's at the point where we'd be like, let's maybe pull it back just a little bit, scooch the catheter, the tube back a little bit. Maybe it's migrated a little too far in. Let's adjust it, wiggle it. If that doesn't work, then our plan Z is replacing the whole thing all together, starting doing the epidural all over again. That is not common. I've seen it. Of course, I've seen that, but it is not very common to go all the way down to plan Z.
Yeah, I would say that we don't see it that often
Yeah.
either. Only a handful of times. And I think just like you, it's like hours into it and it's a last
Mm-hmm.
resort because we do everything. That flipping of your patients, our team calls that the rotisserie chicken stage. And
Yes,
we live
yeah.
over and over again. Okay, so that leads me to my question is, what are your favorite positions
Oh,
with an epidural? What do you love to do with your patients? And I'll tell you what I like to do with my clients.
Oh, I can't wait. So I have a whole circuit. The first thing, it's going to depend, right? So I like to lay hands on every belly that comes my way if I'm allowed and feel how the baby's positioned. And if
Sure.
my baby's like a little wonky in there, because sometimes they do that,
Yep.
then we're going to do like circuit A, right? Whatever circuit I have in mind to scoot my baby out of the pelvis, flip them in a good spot, and then move forward. But otherwise, if baby's not necessarily wonky, we're in a good spot and I just can do like my generic little positions. Once they get the epidural in, I like to let them have a good nap for an hour.
Hmm.
I put them on their side. I like to have a peanut ball in place, and
Nice.
it's almost like you're in a run. It's called exaggerated sims. So
Oh
imagine
yeah.
if you were like looking at yourself in like a mid run, like your leg is stretched out like you're in the middle of a run. I have the peanut ball tucked under the ball. The leg that's on the bed, touching the bed physically, is yanked pretty far back. And then the leg that's up facing the ceiling is going to drape over the peanut ball. And I'll just let you take a nice long nap like that. We're going to open that pelvic inlet. And then when you're feeling a little recharged, because I just think it's cruel to you finally have you finally have pain relief. And then I'm like, let's get
Flip,
hands and knees.
flip,
Yeah.
flip.
I just like to give you a little reprieve. Once you've gotten a good little nap, I'm like, all right, let's get to work. So we'll do the exaggerated sims. And then from there, if my patient is up for it, I like to do side lying release on each side, which is a stretch. You can go to spinningbabies.com. It's a stretch to loosen up the fascia and the muscles. And then from there, I do something called Captain Morgan's. Do you know what that one is? Yes. Oh, I
Yeah, I
love that
do.
one.
I love Captain
Cap-
Morgan's.
it is my favorite. We do 3 contractions with the one leg, then we flip to the other leg and do Captain Morgan's for 3 contractions. And then from there, I like to, depending on how my patient feels, I like to do a princess or a throne position. Uh,
Frog.
Oh, that's a good one. I like that. Yeah, and then I like to put them up in the princess or the throne and maybe use a peanut ball. Again, it varies depending on what position my baby is in. So if the
Hmm.
baby's in sort of something wonky, we do a really different circuit. But that's my generic circuit.
Yeah.
And then if the
Um,
baby is not engaged, another good one is flying cowgirl.
I was just about to say, do you
Yeah.
ever put people in flying
Oh,
cowgirl?
yeah.
And then we also do open knee to chest with a small
Mhm.
peanut ball between
Yes.
their feet and their butt, and they can sit back on it and they still have that
Yes.
nice incline in the back. I do something very similar to you. I just say choose 4 of these positions, and these are all things that we've run through with our clients
Mhm.
prenatally. And so they just choose 4, and then we do a circuit of those 4, whatever
Yes.
they want to do. If their contraction pattern, or like you say, their baby kind of shows us that we might need to do something, like coupling of contractions tells me
Mhm.
we should do something, or your contractions do space out or get shorter, that tells me we should do something. But for the most part, we just say choose 4 of your favorite things. We're going to run through those and we're going to do a couple contractions in each.
I love it. I love it.
Yeah.
It's good. And then that's another key factor, like to do some of the more like proactive hands-on ones as a
Yeah.
like an exaggerated sims, the one like I said, we're in a runner with your leg plopped over the ball and you can take a nap. That's more passive, right? That's a great one to just to do something a little proactive while they nap. But for the more proactive ones, we're physically having to do things. We need to have pretty frequent contractions. If my patient is only contracting every 5 or 6 minutes, it may not be the best time for, or maybe not even five, maybe 5 or 10 minutes. That's not the best time for a Captain Morgan
Yeah.
because I like to do 3 contractions each side and to get it's going to take us an hour to get there. So it takes a lot of upper body strength when you can't feel your lower body.
Yeah.
So yeah, that's another thing. It's very dependent on the situation. But usually, if we're getting an epidural, usually we're contracting pretty frequently and we can do all these other awesome moves.
Yeah.
I love it. I love spinning babies. I love that stuff.
So do I. Our whole team knows spinning babies, and we use it very
Hmm.
strategically in labor, because at the end of the day, they are interventions, but they are very low interventions, obviously,
Hmm.
and they work with physiology. So if you're not familiar with spinning babies, you guys check it out. I will link that for you guys in the show notes. So I have a couple of like really common questions I would love to run through. Talk to us a little bit about eating after getting your epidural.
So again, this is going to be something that is dependent and really varies based on the situation, based on how the baby's tolerating labor, the patient's medical history, the facility, the anesthesiologist. Where I work, we've been trying so hard for years to get a culture shift with eating in labor, and we're seeing a lot of progress with that because evidence isn't necessarily supporting the whole like 100% starve a person from beginning to end of labor. That's not really where what evidence supports. The concern with eating during labor is it's very old, back decades and decades ago that this came up. But if things were to become emergent, if you got this exact sort of anesthesia in this sort of situation and you threw up and you inhaled it, it's a very niched out hypothetical scenario. Vomiting and aspirating
Is
is very,
real.
very serious. It is a real
Totally.
thing. So now when you're in labor, you've got a lot of people managing your care. You've got like
Mm-hmm.
your nurse, you've got OB, but you also have anesthesiologists. So anesthesia, they're like, we just want you as safe as freaking humanly possible. I don't care if that means you're starving, right? I
Mm-hmm.
do not want you to inhale this and go septic and aspirate. So I feel like where I'm working, the very last piece of the puzzle is getting our anesthesiologist on board with being a little more open with eating during labor, eating with epidurals, stuff like that. Because again, it is coming, usually it's coming from a good place. They really don't want to have to manage an emergency. But
Who
then
does?
for, yeah,
Who comes to work wanting to,
nobody wants that for you.
Yeah.
Nobody. But then on our end of it, where we do a lot of the birth and stuff, even the OBs, the midwives, the nurses, it's just trying to get them to where I work to change that culture and to start to feel the truth of what the evidence shows us.
Mm-hmm.
It is hard to feel that sometimes. There's always that risk too. So at the end of the day, you can really do whatever you want. If you want to eat when you're in labor, go for it. You do whatever. But it's important, like everything, to understand the risks, the benefits, the alternatives, really understand those things from credentialed sources so that when
Yeah.
you make your decision, it's really an informed decision. It's not just I'm empowering myself by saying no to everything they tell me. That's not
Yeah.
informed consent. Informed consent is I saw all my options and I'm choosing what truly feels right for me. So yeah, I'd say that the evidence these days is starting to like really lean towards like there are benefits in eating during early labor, but again, this is going to really depend on your team, how comfortable they are on it, and your own specific situation. Because even me, as minimalistic as I am about things and hands off, and as much as I eat when I'm in labor,
Sure.
there are some patients that pass through my hands that I'm like, I would hold off. Or
Yeah.
there are some babies that are really not tolerating things well, and I would hold off.
So, in other words, if
So
it looks like you might have a C-section, consider should I really eat now? But if you remain low risk and you're just getting an epidural for pain relief, it's worth considering maybe I
and
should eat if I'm feeling hungry.
if you're stable, if there's no complications, if your baby's looking okay, you've talked it over, you really understand your risks and benefits. Even if you do have surgery, you really you do whatever you want. The
Sure.
key is always going to be that you just understand all the risks and benefits. And this came from a place of knowledge. That's
Yeah.
really what it comes down to. I am not dead set against people snacking, even after they have their epidural. I do not care.
Yeah.
I just had a birth a couple of days ago and she was eating up until delivery and with her epidural. But again, it really is just going to vary from one person to the next. It's really like we want to be safe, but we also want to be reasonable.
Yeah.
So
Yeah.
it's tricky.
Also, I will say if you choose to eat and it's against hospital policy, please don't hide it from your nurse. It's really important that they do know. Just let them know, hey, I made the decision to eat. This is what I'm
Mhm.
eating. Because then they don't send you back to surgery and then report to your anesthesiologist, no, they have an empty stomach. And
Yeah.
actually, you do not, in fact, have an empty stomach. Just
Yeah.
keep your medical team up to date and don't lie to them. You are an adult. You're allowed to make your decisions.
Yes.
Just keep them in the loop if you decide to go against hospital
And
policy, guys.
something I would throw out there too, if we're making the choice about eating while you're in labor, or like with or without an epidural,
Yeah.
regardless, is wherever you deliver. Most places have a policy that if it is not like a straight up emergent, urgent situation where we need to go to the operating room now and have a baby, if you have eaten, they may postpone this turns
Wow.
into a C-section, right? Let's say you were in labor and then we end up moving forward with a C-section, but it's not necessarily urgent, right? They may postpone it if they
Mm.
found out you just ate. So that's just another thing to keep in mind. Again, not like fear mongering, just know that like
Time test the
C-section,
policy.
it's possible. It's
Sure.
C-section. It's on the horizon. It's not the forefront, but it's on the horizon. You take a granola bar and you snack it down. And if things aren't going super crazy and urgent, they may say, let's hold off a little bit since you just ate. It just know that that's a possible thing that could
Yeah.
happen.
Hey. Maybe it plays into your favor and you were about to be diagnosed with failure to the breast.
Right?
You ate, they gave you a little bit of time and your baby gets it born. Like that would be amazing. That
Yep.
would be awesome.
Yeah, that would be pretty cool.
Okay. Yeah, that would be great. All right. What about walking epidurals? Everybody wants one. Here in Boston, we do have one hospital that will do it. I have seen it only one time. It's one hospital, one anesthesiologist. You have to be
Oh,
really lucky. I've seen it once and we still didn't have full freedom of the entire room. We were very limited. We were allowed out of the bed. She got to walk to and from the bathroom. We got to be on the birth ball and we got to stand like right along the side of the bed, but we didn't have like full range of the room, but it was really nice to be able to get out of the bed. And it was so, it just like really blew my mind to see her have an epidural and also be able to walk because she
it's
walked really well. It was
unbelievable.
crazy. Yeah.
Unbelievable.
What do we need to know about walking epidurals? I prepare people for they're probably not going to be an option, but if they are, what do they need to know?
So I have nowhere near the experience with walking epidurals that I do with pretty much everything else in OB because we do not
Sure.
offer them where I'm at. And so
Oh,
I'd say no, number one, know this, they're extremely uncommon.
yeah,
They
very
exist,
rare.
they're out there, but they're not very common. Again, add it to your prenatal appointment questionnaire that you've got for your provider. Two, that I think I feel like you've already hit the nail on the head right there. If you do find somewhere that offers walking epidurals, what I would expect is it's potentially there may be like a little less pain relief because you still have that mobility. Or if you have great pain relief, you have the mobility, but they may limit where you can go in the event that you're starting to feel weak and you need to be sat down or get in your bed or something so that you don't fall down. They're just very uncommon. We don't even offer them where I'm at, but they exist. They're like these little unicorns out
Yeah.
there.
Yeah. I always just think about how lucky we were. That was that client's preference. She was also an L&D nurse on that floor at the time.
Wow.
And it was just like all the stars aligned. And I just will
Whoa.
never forget the mind blowing feeling. How you're just looking at something like, how can this be? That was
Yes.
me the whole time. I was like, I just do not understand that. Very
Yes.
cool. Don't get me wrong, but I am just mind blown right now. It was very cool. And she ended up having a great labor. And it
Wow.
made me actually wish that they were more available because they're a really
Hmm.
great option for people. Okay,
Yes.
we hinted at this earlier, but common complications. People always want to know what those are. What
Of course.
should we know about complications?
There are like shades of complications. There are really minimal
Sure.
ones, and then there's more serious ones. The good news is that the more serious ones are extremely uncommon and rare and unlikely to happen. So let's talk about the serious ones first, right?
Okay.
Being paralyzed. It's virtually not happening. And if this is helpful for people to hear and like more recent studies, even I think when you pull studies even from the past like 10 plus years, there hasn't been one single maternal death ever associated with an epidural at all in 10 years out of the hundreds and thousands and millions that have happened. So that we can get out of the way. Nerve damage, again, not common at all, but it can happen. But again, it's not common. If there is a little like nerve damage that takes place, usually it's minor and is something that can heal on its own within days to a week or two. Some more common ones that I see that are probably like more problematic for people, spinal headaches. So that probably happens 1 out of 100 people is what I think I last read. So again, not super common. That's about 1% of the time, but they're a bear. What would happen is when they place the epidural, sometimes you can puncture, I think it's the dura and the anesthesiologist listening. I'm so sorry if I'm wrong there, but
You're right about that one. I do know
okay.
that.
They're gonna be like, what is this nurse up here talking about this crap for? Like, get her off, give her the yeah, you can puncture the dura and then your cerebral spinal fluid can leak into that space. That sounds really scary and serious. No, it's not the worst thing ever, but
And
what
it
it
can
can
be
do is
replaced.
it can be, yes.
Yeah.
And, but it can give, what happens is after you've delivered, after the epidural is taken out, and now you're postpartum, you will have a bear of a headache, usually the front of
Mm.
your head, the back of your head. It just a really bad headache, really bad. And the hard thing about those is there's a lot of things that can cause headaches when you're postpartum, from preeclampsia to sleep, being exhausted and all this. So it can take a little time to figure out that it's a spinal headache. There are things we can do to treat it. You can get regular over-the-counter medication. You can get caffeine drips. You can do something called a blood patch, which what that does is they literally, just if you place an IV, they put it in your arm, they draw back a little bit of blood if you got blood work. They go exactly where your epidural had been placed. They squirt the blood there and close up the leak. and that usually takes care of it. Isn't that cool?
Wow.
I
Yes.
know, but that happens, and that is not a fun thing to experience when you're caring for a newborn. Again, not a common, but totally possible. Another thing, there's a
Wait,
higher
hang
risk,
on. How long is that spinal headache lasting after birth?
can go on days. Usually when you're laying like horizontal, it starts to feel better. But if
Mm-hmm.
anytime you get up, it's really bad. It's really bad.
Okay.
So yeah, I'd say if you're a day or two postpartum and that headache kicks in and you've taken Tylenol and nothing is fixing it, I always want to know because one, I want to make sure it's not preeclampsia
That's what comes
or,
to my mind
yep,
every time postpartum with
everybody
a
thinks,
headache. Every
yep,
time.
every time. And I want to make sure we're not anemic or a spinal headache. All of those
Mm-hmm.
things need medical attention, right?
So you're most
So
likely going back into the hospital. If you call and say I have a headache, you would want your provider to see you
it,
at that
you would,
point.
I would expect if you're getting a crazy headache and it is a spinal headache, it's going to start showing up either over on the postpartum unit or the day you get home. It starts to happen those first initial days, not hours, but like 1, 2, 3, probably not 3 days, 1 to 2 days after you've given birth.
Okay.
Next complication that people should know about is there's a higher incidence of maternal fever.
Hmm.
It doesn't necessarily mean like an infection in and of itself. It can be like an immune response, an inflammatory response to
Oh,
having this sterile procedure. We don't really know much about why this happens. I have tried so hard to learn about it. Nobody knows.
hmm.
But it's a higher incidence of that happening. And we know a fever during birth can cause complications for you or your
Sure.
baby. So it's again, not very common. And it is something that is specific to people in labor. A lot of people get epidurals before surgery or get spinals before surgery. They're not pregnant, and we don't see this happening with them. So we think it's
Wow.
very interesting. It's something to do with whatever's going on with that mother baby dyad and what your body is doing and getting that epidural. It's very uncommon, but it can happen and people should know that.
Now, is that going to send you down the path of getting antibiotics in
Very
labor?
possibly, because they may want to treat you for an infection, thinking it's an
Sure.
infection. So that's again potential. That brings us to our next potential side effect is it's so uncommon, but it is possible anytime you're introducing a foreign body into your body, anything from an IV to a cervical exam to a heart transplant, there's always going to be a risk of an infection. And that's the same thing with getting an epidural placed. That risk is extremely low. The procedure is done sterilely, meaning there is no living organism on one single thing that is touching your body when we put it in. Other more common side effects that I see would be the dropping of the blood pressure. Again, it's not common per se, but it is a more common complication. Your blood pressure, when they give you that medication, can drop very low, can make you feel woozy, give you a headache. And then where this would become more problematic is if when your blood pressure gets really low, then that is we're talking about our placenta, how we're feeding baby, right? Giving baby perfusion and blood, then we may have trouble perfusing baby well, and we might start to see heart rate abnormalities on the monitoring, see that baby's having a little bit of a squeeze or a head rush, or almost like if you were to hold your breath and dunk underwater. That's what can happen to baby when your body's in stress. They have these little dips in their heart rate. Usually, I don't see that happen often, but it totally can happen. Usually we can correct that. We can help using very minimally invasive things, just changing your position, giving you a little bit of extra fluid. If you need a medication to boost your blood pressure, that can happen, but it's not very common. And then worst case scenario, like really worst case scenario, baby does not recover from this distress. And then we would go and have an unexpected, like emergency C-section. Again, that is not likely. It's not common, but it does happen. And that is one risk of an epidural. I think probably the most common risk, there's more, I'm sure that I'm missing, but I'd say probably the number one risk or side effect of an epidural is that 1 out of 8 people do not experience the pain relief that they were anticipating. I think that's important for people to know that. And it's also important when we're talking about just having like other ways of coping for pain when you're gearing up for birth, regardless how you give birth, C-section, epidural, birth, vaginal, unmedicated, there will be discomfort involved. And it's good to have a way to cope. And that is one reason, is because 1 out of 8 that's not 1 out of 100. That's not
That's a
one out of a
lot.
million. That's a
Yeah.
good amount. There's a 1 out of 8 chance that you may not feel happy with your epidural pain coverage. That doesn't mean
Mm.
you'll be in excruciating pain, but it does mean you'll be like, I want it better, and it's not better, and we can't fix that. So again, just these are the most common risks, the top risks I see Are there any that you're thinking of that I'm not thinking of?
Yeah, two that are commonly brought up. People are very worried about postpartum hemorrhage. Does it increase my risk for postpartum hemorrhage and does it increase my risk for C-section? Are they direct connects? Maybe not. Do they often happen together? Sometimes we can see that. Is Pitocin often in there somewhere? Yes, it usually is. And we have to look at how are we using Pitocin? Was it an appropriate amount? When your patient and my client got to a place where they were having adequate contractions, did we leave them there or did we continue to pump it up? Did we pit to distress? There's a lot of other things that go into it. So what are your thoughts about epidurals and counseling people on the risk of postpartum hemorrhage and C-section?
Yeah. So I think like when we get into the effects of now we're going beyond like risks of an epidural and we're talking about how could this potentially affect your labor, right? And it becomes its own secondary little baby risk for your whole labor, right?
Yep.
Evidence-based birth has and so many amazing resources about all about epidurals, right? And it's just straight up evidence. And one thing that they talk about that I think probably encapsulates this whole topic really is that if you do choose to get your epidural, which one benefit is it is accepted as the most effective form of pain relief for birth, right? If you choose to do that, then you need to find peace or accept that it is a part of a bundle of medical things, right? Expect a bundle of things. And this isn't like you're losing consent. We're going to come at you. We're going to do things you don't want to do. It's just in order to do that safely, to get what you're needing out of your epidural, what you want to safely monitor you, your baby, there will be a bundle. There will be a bundle. You'll be on fluids, very likely. You'll have a blood pressure cuff, very likely going off 2 times an hour till you deliver. You will have that little thing on your finger checking your heart rate and your oxygen for an hour or two, on and on.
Continuous fetal monitoring.
Fetal monitoring has got to be on there, right? Because we talked about how this could affect your baby. Other things to keep in mind are that there is like research out there that it is maybe more likely that you may need Pitocin if you choose the epidural. Something that I think is important to discuss is that, and this is where we get in that weird land of like exclusively talking about side effects from the epidural and the medications versus
along with all those other things.
Yes, the bundle.
Exactly.
So there's like so we've covered just the epidural and exclusively things that are only attributed to your epidural and your pain medication. Then we have the medical bundle, right? What are the side effects of that? The side effects of not being able to feel your legs super awesome is that you are going to be in your bed. We talked about how if you've got a good nurse or a doula, they can like freaking flip you around on your head and do acrobatics in your bed. What if you don't have a great nurse in there? What if you don't have someone who's helping you move? Then the evidence shows us that there's a higher likelihood of having a prolonged labor or prolonged pushing phase, right? That wasn't the epidural in and of itself. That wasn't the medication. That wasn't us putting it in your back. But this is part of that medical bundle, right? That now we aren't able to do the mobility, the movement, which evidence shows us will help facilitate labor and pushing and birth and all of those good things. We can still mimic all of that stuff and have a proactive, good moving forward with labor experience with your epidural in place. But that's why it is important that you have a really good proactive team who's supporting you physically. Because if we don't have that, then we've got these secondary issues of if you have somebody who's just, we say this at work, a couple of my friends and I, if you've got a nurse who is just, you pop the epidural in and they just let you slug it in the bed, right? Like just imagine just straight up a slug in a bed. That's all they're doing for you. Here's your epidural. Like they walk out, don't do a thing. They just leave you flat, horizontal. Then we're not opening your pelvic inlet. We're not helping with contractions. We're not using gravity. We're not working in relationship with the baby's position. We're not being proactive. What does that do? It means like our labor could be longer. It means our contractions may space out. And that's when we see, let's talk about Pitocin. Let's talk about breaking your water. Let's talk about this cascade of medical stuff. And again, that's where we talk about the higher risk of hemorrhage and using when you have an epidural in place. If we did have a longer labor, if we did need Pitocin, if you didn't have somebody who was helping you be proactive after the epidural was in place, then there are now risks with longer labor. There are now risks with Pitocin, which include like possibly an assisted birth, meaning like vacuum, forceps, possibly hemorrhage, things like that.
Uterine atony, all that is
Yes,
associated with higher tearing. That's its
exactly.
own cascade
Exactly.
of things.
Yes.
Everything you have to think about when you make a
Mm-hmm.
decision now, what is down the ladder that you're not
Mm-hmm.
thinking about that now you're signing up for?
Yes. So that's where it's so tricky. So it's if we have column A of what is specifically and exclusively uniquely attributed to just the epidural and the medication we put it, that's all the stuff we hit on.
Mm-hmm.
But then we have to think about column B and see if just now there may be we know that if you have your epidural, there may be an increased likelihood of a little bit of a longer labor, not much. We didn't see like like it was hours and hours
Yeah,
longer when
2 hours,
evidence.
I think, maybe
Yeah,
four
it
hours.
wasn't. Yeah, and that varies. There were some that
Mm-hmm.
said 15 minutes for push.
Mm-hmm.
It all varies on what studies we're looking at. But still, it's there. And when we have longer labors, then that has its own side effects. It has its own interventions. The interventions have side effects. So these are things to keep in mind. And I'm most certainly not like disparaging epidurals or one way or the other. I'm a huge believer in everybody's unique, and I want the safest, emotionally, physically safest thing for them and their baby at that point in time. And that's going to be super different for everybody. But I think going back to informed consent is knowing that just like when you get your epidural, just expect this bundle and expect
Sure.
issues B, C are on the table. Doesn't mean they're going to happen, but they're on the table. So, yeah, good stuff to talk about. Yes.
Yeah. For people who are on the fence about getting an epidural, or maybe they're in the moment and they're trying to decide whether an epidural is right for them, I have two pillars. I always say if it's not a hell yes, then wait a little bit longer. It will eventually become a hell yes, or you'll
Yes.
have your baby without it,
Yes.
right? The second pillar I always remind people of is consider whether you're coping or you are suffering, right? I don't want you to
Mm-hmm.
suffer in labor. And sometimes we've reached a place where we really do need extra support. Talk to us about how you help your patients make the decision of should I get that epidural? Is it the right time?
Honestly, I feel like all I'm doing is just like echoing the exact answer you gave.
Yeah.
That is what I see. People, if they came in for an induction or they came in early labor and we're at a point where we can have a really great in-depth conversation, which is most of my patients,
Yeah.
honestly. One of the things we talk about is when's the best time to ask for their epidural if they want it. And then something I see anecdotally, and that most of my patients experience is if they were on the fence about it, or they're not sure when to ask or if to ask, if they even want it, that's exactly what I see. There's a point where they're just like, yeah, I want it. There's no doubt. I feel
Yep.
zero discomfort with this decision
Yep.
whatsoever. If they are feeling doubt, discomfort, fear, anxiety, if they're questioning themselves, this goes for anything, not just epidurals, freaking anything. I don't want them to move forward with something unless they feel comfortable moving
It's an
forward with it.
enthusiastic yes. We're looking for
Yes.
a full on
Exactly.
yes.
I want consent. And so that the same thing with an epidural. And I'd say most of the time, those pillars that you have pretty much apply to anybody. If they were unsure about getting an epidural or not, they usually get to a point where they're just like, and now, and then there
We're
is
good.
no question, or they're like, I don't know. And then we're pushing, you know what I mean? So that's pretty much, yeah, I have nothing to add to that. Pretty much where I'm at with you.
Nice. All right. I have two other questions.
Sure.
Who can place our epidural? We've mentioned anesthesiologists, we've mentioned CRNAs. I know a lot of people are very hesitant and they say things like, I don't know if I want a resident to place my epidural. Talk to us about who might place our epidural and what kind of questions we should talk about in our prenatals with our provider to determine what's right for us.
That's another great thing to talk about. Depending on where you deliver is also going to change the scope of who may be putting the epidurals in. So
Mm,
if you deliver it like a private hospital or a rural hospital that is not a teaching hospital, they don't have any students there. It's just like the staff is the staff, and that's that. It's very likely that the only people who would be placing epidurals would be just anesthesiologist or a CRNA, which if that's a new phrase for you, a CRNA would be like a nurse, a registered nurse who has gone and done continuing education and got more schooling, more credentials, passed more bars to do a lot of what an anesthesiologist does, but they're not a medical doctor. They're a nurse doing very similar work, right? They can't, not necessarily the exact same scope, but placing epidurals and spinals totally falls within their scope and they do great at it. That's scenario A, right? Scenario B is if you're delivering at a big hospital that is a teaching hospital or a research hospital and they've got students and residents and interns and all those other things that people have no idea what the difference is, right? We're in situation A, it's a safe bet that it's going to be an anesthesiologist or a CRNA. Situation B, it could be an anesthesiologist, a CRNA, it could be a resident. I believe it could be an intern. And if we don't know, and now we're getting into the whole hierarchy of learning a doctor's path of education, but even that, like an intern is usually it's their first year out of, they've become a doctor. They are a doctor. They're not a student, but it's their first year practicing as a doctor. And they have to do there's all sorts of learning criteria, things that they need to do hands-on. And that is their first year doing it. A resident is usually like second, third year doing it. And then you have an attending who like they're full-fledged, that is in the rearview mirror for them. Like they're the big shot, right? The good news is if you're at one of these places that has learning doctors, right? An attending is always overseeing these learners, right? And a learner doesn't mean a student necessarily. A student may observe the placement of an epidural. If you allow that, you can say, I don't want you here, bye-bye. But they would not be assisting it whatsoever. If you have an intern or a resident anesthesiologist placing the epidural, where I work, the anesthesia attending, right? The big shot who's been doing this, and this, they know it like the back of their hand. They are physically present, eyes on, watching as the resident or the intern is doing this. If it becomes too hairy and they're like out of the way, they will take over. So that is the good news. With all that said, you can still say, I just want an attending to do it. I don't want to, no fussing with all that stuff. And if they're able to facilitate that, then they should. Another good thing is like a resident, especially, they're literally solely there to do these skills around the clock all the time, day and night, forever. Unless they just started a couple weeks ago, they're usually pretty darn good. Maybe they'll be slower, right? They're taking their time, they're slower, but they're usually pretty good. But I think it's good to just understand that if you're worried, is a student going to be putting it in? No, that should not be the case. You have the right to decline students or residents or interns and just ask for the attending or a CRNA.
Yeah. Okay. I know I told you I have two more questions, but now I actually have two more
Go
questions.
as many
One
as
thing
you
that
want.
we did not talk about is getting a catheter with an epidural. Do we need one? What's the evidence say about a straight cath versus like cathing you every time? Are we taping it to our leg? What should we expect from being catheterized? How do you say that?
Yeah,
with
that's
an
exactly
epidural?
right. Yeah, so that's another, like, that's a big topic, right? So we talked about how if you can't feel that mid upper abdomen down to your feet, unless you're one of the unicorns that get a walking epidural, you cannot walk to the bathroom, right? So we have two options from there. We can either offer you a bedpan, which I have done, but when we blocked off that sensation, like your brain talking to that nerve in your lower spine, what happens, and if you're a nurse listening to this is going to blow your mind, because nurses are going to sit there and think you're just going to be incontinent, you're just going to leak your pee everywhere, you're not going to feel it, you're not going to hold it, it's going to pee all over the bed. No, when you're in labor, what happens is the bladder has to contract and it needs to relax in order for you to pee, right? So when you're in labor, it does not relax. It does not just let it all out and you have incontinent episode after incontinent episode. What happens is it just holds it and it retains and returning all the pee that you've got. There can be problems with that. We need you to pee.
Oh, yeah.
It can throw our labor off course a little bit because it's right by the uterus. It can upset baby a little bit. It can
make it where baby literally won't drop in the
will
pelvis.
not drop. Totally. It can throw off your contraction pattern. It can, because it's right there by your uterus. They are not friends, the uterus and the bladder, not buddies. It can also increase your risk for a UTI if we just like in normal life, if you're holding onto your pee too long, can cause a neurogenic bladder because we've overstretched it and we have issues afterward. All this stuff.
Postpartum hemorrhage even increases if you have a full bladder.
Yes, 100%. All of that. So we need to empty your bladder. What we can do is offer the bedpan. But like we've said, we've established like your body is just going to hold. Me putting a bedpan under my patient doesn't change what we have done, right? It doesn't change that. And then all of a sudden the brain is, oh, let it go. I've seen it happen a couple times, right? Oh, I've seen it happen a few times. I have seen people, I was like, all right, then you do you, girl. And I always offer it to my patients. I always say, do you want to try a bedpan or do you want me to do a catheter? If they want to try, like I am all about it. I just set them up to know it's extremely unlikely. In the past
Okay.
decade, I've had 2 people ever be able to do it.
Yeah, I've
So
never seen that.
set up that expectation now. So
Yeah.
then our next option is you can do a catheter, right? And the ways we can do that is a lot of places will just put the catheter in, secure it to your inner thigh with an adhesive, and it just stays in there the whole dang labor, continuously keeping the bladder empty. That's great, but there is always a higher risk of a urinary tract infection when we have the catheter in place, right? And the last thing that we can do regarding the catheters is we can do in and out. And what that means is that every X amount of hours, we put the catheter in, drain it, take the catheter right back out, usually 5-minute process, and then just leave things as they are. 2 to 4 hours later, we do it again. And all of this is sterile. It should be sterile. And we just keep your bladder empty to avoid all the problems we talked about. Where I work, that is now the practice that we have. We've been doing that probably 7 years, maybe 8, but we did used to do these continuous like indwelling catheters that were just there forever and ever. Amen. We changed our practice because there were some early studies showing that there was actually a lower risk of urinary infections when we stopped just leaving them in there 24/7, right?
Wow.
These are smaller studies, and even since that has been put in place, there's some mixed reviews. The good thing is even if you go to a facility that is just doing taking them out a few hours later, doing it, taking it out, that isn't a higher risk of an infection than just leaving it in, if that makes sense.
Mm-hmm. Yeah.
So if you have a personal, neither is necessarily overwhelmingly better than the other. There is some studies showing that doing the in and out, just in and out every few hours, may have a lower risk of infection. Personally, I just feel like I've seen less infection now that we've changed our practice. But again, that's not science. That's just what I've seen.
Yeah. That's
Yeah,
kind
so
of
that's what we
crazy.
know.
It feels counterintuitive
Totally
to
does.
me because I feel like every time we'd go in and out would be an introduction of bacteria rather than just one and
Absolutely.
leaving it. But
Absolutely.
hey, I love that. It really does open up the door to what is that patient's preference? If one is neither
Mhm,
like really good or bad over the other, let them choose. Do you want me to do this
mhm.
once and tape it to your leg, or would you rather me do it every couple hours?
Yeah, and like I said, there are some studies that it maybe, like I said, we changed it because there were studies coming out showing that
Yeah,
doing it
that's
in and
awesome.
out has a lower risk of infection. But again, it is not like a study of 200,000 people, right? It was
Sure.
small. But I think it was, we were not about it when I'm not gonna lie, I was the first. I was like, there's no way. Like this is ridiculous. I'll do what they say, but because I'm all about science, but this does not
Sure.
feel right. But since then, not only seeing it play out that way, but also when I really think about it, it does make sense. Because if you think about, we like a cervical exam versus having the IUPC or an FSE in place, right?
Mm,
We know IUPC or FSE, when that is in the vagina and it's just hanging there for hours and hours, you've got blood, you've got the bed sheets, you've got pads, you've got fluid sitting on that tube
mhm,
right there at the entrance of the vagina, literally crawling all the way up into your cervix. It's the
mhm.
same concept with an indwelling catheter that's there 24/7 versus
Hmm.
us just going bloop. So it does feel like, oh, the more we introduce it, there's going to be a higher risk of infection, but we're doing it sterilely. And in between, we don't have a pathway just shooting right up to the urethra nonstop.
Yeah,
So
yeah,
that makes sense. So yeah, cervical exams totally can increase the risk of infection, but they still have a lower risk of infection than an FSE and an IUPC
sure,
because it's just in and out versus continuous. So
sure. Yeah,
kind of similar logic.
yeah, that's crazy to think about. Okay, we
Yeah.
finally made it to my last question, and I promise this is the last
No,
one.
you're
But
fine. You're fine. This is
what
great.
do we need to know about taking out the epidural? What is that process like? When will we do it after our baby gets here? And then how long are we going to stay numb for those first few hours after birth or after we take it out? And do we turn off the medication before we take it out, or do those things happen relatively simultaneously?
So that is such a good thing to talk about. When you get your epidural, it's up and running, like you're feeling Gucci over there, right? And then we've got that thing going and going. Ideally, it is going to run throughout the entire course of your labor at a low dose to just maintain that level of comfort. We talked about ways we can troubleshoot it if we have breakthrough pain. And then at the end, in at least where I work, the way I practice, and most of the people I know practice, I'm not going to shut that thing off unless you either ask me to, or it is
Mm,
straight up inhibiting or pushing or something like
mm.
that. So it really should be working and keeping you comfortable up until baby's here. I don't personally turn it off until my placenta is delivered and I know our bleeding is under control. Because
And
another benefit,
stitches are done, any sort of repairs?
all of that, yes.
Yeah.
So one of the benefits of your epidural is that you can stay comfortable afterward. If you were hemorrhaging and we had to do all kinds of
Mm,
crazy things, right? You are not feeling what is happening on your tummy or down there. If you get stitches, you shouldn't be feeling that. It's going to be way more comfortable than if you're unmedicated and getting like just numbing agent injected while your stitches. So I like to wait until, as much as I can anticipate any postpartum pain, I try to wait until the bulk of that is in the rearview mirror and then I shut it off.
nice.
Once it has been shut off, I usually expect to see my like a return of sensation, mobility, motor skills within about 2 hours. And it is a slow
Okay.
return. So again, depends on how heavy the epidural was. For some people, it comes back quicker. Others, it takes longer. I like to tell everybody there's always a bum leg. There's going to be, usually
Yeah.
is it the left for you? It's always the left for me.
I don't know, but there is always
It's always a
one.
bum leg. It's just, I'm going to take a nice
Oh,
little nap
funny.
and it doesn't want to come back. So that's a little
And
weird,
we
but
laugh, but that actually can feel very scary, right? Like,
scary.
I do get it
Oh,
if you're out
yes.
there being like, wait, I was not laughing when that happened to me. Totally scary. I hope if you're planning on an epidural or you get one in labor, that's normal. Sarah and I
There's
are
a bum
laughing because
leg
it's
there.
it's so normal. It will return. Your feeling will return,
Yes,
I
it
promise.
is so weird. And but usually the left for me is like the left leg is the bum
That's
leg.
hilarious.
Oh my gosh, I don't know. Maybe our people are right-handed and they're go. I don't even know. I have no idea. But so like I shut it off. So what I like to do, this is getting so like straight up nursey niche, okay? I don't take the epidural out right away, right? I am a cautious little Nelly. So I'm like,
Yeah.
I don't trust any of your uteruses, okay?
Okay.
So your uteri. So if you are feeling good, if your bleeding's good, all of that stuff, I turn off the pump, I disconnect the medication, but I leave the catheter in place and taped up. I do all my fundal exams, all the stuff if you allow me to. We keep you clean, we empty your bladder, all the fun things. You're cuddling on your baby, life is good. You forget the thing is in your back. When I'm at a point where I'm like, we are 1.5 hours. I've shut after delivery, the thing has been shut off an hour and a half. Your feet are starting to lift, you're wiggling your toes, it feels as if when you sat on your hand a long time and then it fell asleep and starts to return pins and
Mm-hmm.
needles. That starts coming back. It's been like maybe an hour and a half since you delivered. If I'm like, our bleeding is good, you are stable, your blood pressure looks good, you're cozy, I'm expecting to say that you are recovered and can enjoy your baby on the postpartum unit, that's when we take it out. Because I don't want to take that thing out that I know has worked really well if all of a sudden your body throws me like a little curveball and says, and I'm going to hemorrhage. I want that in place so that all I have to do is like bloop, connect it
Get it
again,
back started.
get it started
Yeah.
up again, and you don't need to feel all that stuff.
What?
So a lot of times, so where I work, the anesthesiologists are the ones that remove it, and removing it is so
Oh,
easy. It doesn't have to be an anesthesiologist. Oh, most nurses do it. I've done it with,
sure.
but we usually leave it up to them. Just again, they're learning, they're practicing.
Oh, sure.
All it is literally just peeling the tape off. That's the worst part of it. It does hurt. It's not fun. There's tricks to make it not hurt so bad, but peel the tape off and then they just bloop, pull it out. Nothing. You do not feel that thing coming out. It's just the tape is the uncomfortable part. Yeah, usually the anesthesiologist will circle back around or I'll check with them and be like, can I take it out now? Usually they ask me, can she get her epidural out? And I usually tell them, like, come back when she's 1.5 hours postpartum,
Wow. Yeah.
because I just like to have it in place if something really crazy happened. And we have options for pain management.
Totally.
So for really intense pain management.
Yeah. Cool.
Yeah.
Oh my gosh. I feel just so educated now about so much. I feel so, I don't know. I feel like I knew a lot coming into this conversation, but I feel like we touched on things that I've never even thought to ask about or think about or talk to people about. So thank you very much for that. I think my final place that I want to leave this is as a nurse. What do you say to someone who is not sure the epidural is right for them and they just cannot make up their mind? What's your advice to them?
Usually I see that happening before they've gotten to that place in their labor. Because, like we said, they usually get to a place in labor where they're just like, it's a hell yes. And then whatever lingering fears are gone. So when I'm having this conversation and they are just really torn about what to do, if we're pre that, I just try to reiterate to them, you do not have to do it. You do not have to do it. This is all of this, all this stuff we talk about, everything in the birth lounge that you're talking about, it is all to equip you with the mental, emotional, physical, like tools necessary to get you through this life-changing experience however you want.
Yeah.
And it doesn't matter. To me, I do not care if you get an epidural or not. I don't care. They're wonderful. They're or not. I love it all. I just want my patient to feel peace about it. So I never, if they're feeling like any doubt of, I just feel about it, it doesn't feel right, then I usually do say, let's hold off. And I like to bring it up to the next thing of what is it you're most afraid of? What is it you're most nervous about? What is it what are you most concerned about? Because I can either address those and relieve those concerns, or I've addressed them and those concerns are now greater. And then that's your answer. You don't want it. And it comes down to two camps: people who are on the fence, the people who are, maybe they have these lingering concerns, but when push comes to shove, they value the pain management or the benefits of, they have the epidural in place if things did get really emergent and they don't need to be under general anesthesia. They value that more and choose those benefits over whatever risks were concerning them. And then if people in camp B who are just so uncomfortable with whatever it is about the epidural, with the idea of it or the bundle of medical stuff or whatever, that the concern about that outweighs the potential benefits of the pain relief. There's nothing wrong with that. So it just is going to come down to what people are valuing and what feels the best for them at that point in time. And that's different. Everybody's different.
Yeah. Oh my gosh. I have loved this conversation. I, for one, am really grateful that we live in a time that epidurals exist.
Me too.
And I, like you, respect whatever people choose. I really don't care what you choose, but
Mm-hmm.
I just want you to choose it out of a place of, I made this decision. I feel
Yes.
confident in it.
Yes.
And let's get my epidural because I'm excited for it.
Exactly. Yes.
I
And
think that's the game changer for a lot of people, just feeling in control of their birth.
It's true. I've even gotten into like spats with one of our anesthesiologists once because my patient she knew she wanted an epidural at some point. And he went in there. This happens a lot. It's not necessarily bad intentions, but it just happens where providers, staff can accidentally tell people what to do instead of asking. And
Yeah.
they went in to do a cervical exam and they just were like, all right, let's get your epidural and break your water. She had a plan for that to possibly happen. She wanted an epidural at some point, but there was no conversation of, are you ready for this? Is this what you want? Let's talk about the risks and benefits. Do you know what breaking your water entails? All of that. So it wasn't even that she didn't want an epidural and she was concerned. It just, she was being told that it was time to do this. And so she was very comfortable, and the provider just made an assumption that because when you break your water, the pain usually intensifies. So let's get it in place before the pain intensifies and we break your water. There was no conversation. There was no discussion. So when they left, my patient and I had a conversation and she was like, I feel fine, whatever they think I should do. And I'm like, no.
What do you want to do?
Exactly. She was fine. And she ended up not getting it for like maybe another 3 hours. And it wasn't at that point, it wasn't about the epidural. It just was about like her being in the driver's seat. And when she got it 3 hours later, I walked in and it was a very confident, like, I'm ready. And
Now's
that's what
time.
I want. I'm ready. I don't want, if you think so,
Yeah.
it's a huge deal. And I think something I like to put out there when we talk about consent, informed consent, all of this is that I had a midwife once say that to my patient who was changing her plans for her birth. And they were like, birth is just like a drop in the bucket at the end of the day, diminishing how important it was. And I get that. I get that we're like, yes, we don't want to overly commit to things and blah, blah, blah. I get all that. But okay, maybe it is a drop in the bucket to parenthood, to life, to recovery, to all of that. But it is one of the most important damn drops that you're going to come across, because the way your birth goes is going to really has a huge influence on your recovery, on your parenthood journey, on how you view yourself, how you view the people around you and how they supported you. Birth trauma is huge and real. And I think we need to make sure we get it right when we're looking at this little drop in the bucket. And at the end of the day, it is not just healthy mom, healthy baby. That's the freaking lowest bar to set. How insulting. How insulting. You're alive, right? It's an
Yeah.
insult. I think we can honor the fact that plans change, that maybe the outcome was a little different than you had anticipated or preferred, but you can still have a minimally traumatic journey. And I think educating yourself, having consent, being in charge, having a good support system will minimize your trauma, will put you in charge. And then that is going to, even if, say, you do end up with a C-section and you wanted an unmedicated vaginal birth, the C-section isn't inherently bad in and of itself. How did we get there? If your journey, you look back and you're like, I have peace. We made good decisions. I feel good. I was in control. Nothing was pushed on me. I felt educated, and it was a C-section. And it's disappointing, but I feel peace. That's an atraumatic birth, even though it wasn't the outcome you wanted. And I think that's how we need to be looking at this stuff.
Oh my God, I would give my right leg to have all L&D nurses be like you. I just feel like we would have no birth trauma like that. This is the epicenter of where all trauma stems from.
Yes.
Making sure that our patients actually are centered, that our clients are the ones that are making the decisions, asking questions rather than directives or telling them what to do is just so important. Oh my God. Sarah, you are just literally a golden human, and I love you so much.
That is you. You are just an amazing woman. I just love that you invited me on. It's been so nice talking to you, and you're doing amazing things.
Well,
You
thank
really
you so
are.
much. Yeah, I'm so glad that we get to share this space. It's an honor. And I'm just really glad and happy that the universe crossed our paths because
Yes.
I don't know, being in your energy feels good. And you're really the change that I think a lot of women out there are looking for in the birth space, because having a baby, especially in the US, feels scary because we only hear of scary things, but then there are
Yes.
people like you, and it reminds me like there are beacons of hope, and it's changing every day. It's getting safer every day. Like we
They are
are
out
making
there.
moves.
They are
Totally.
out there. And if you are just like needing a little injection of hope out there, because it can feel pretty like dark and dismal,
Yeah.
especially when you're like us and you're like, we are trying to champion like a revolution in the birth world and
Yeah.
having safe care, but also informed consent. It can feel like, man, am I just like the only one? Like, even in my little world where I work, I've seen leaps and bounds in a lot of ways, things that I'm like, wow, I do remember back when I started a decade ago that this is different. Like, we're talking about eating in labor, and that's changed a lot. It is not at all uncommon that we send someone who's a couple centimeters to the cafeteria and they fill up on some. That was not happening 8 years ago when I worked there. And shutting pit off, doing little pit rests, the way we manage our pit, minimizing it is the least lowest dose, as short as possible. That's all a big difference than pit to distress 10 years ago,
Yeah.
which I never was on board with, never would do, but the fights that I used to have with people.
Yeah.
So that for even my little world, my culture where we are, it is changing, and that's hopeful. And there are a lot of he-he's out there. There's a lot of Sarahs out there that are like fighting the good fight. It doesn't feel like it, but like they are out there. So
They are. And
yeah,
we're finding each other. And that's for
finding each
me
other.
is so nice and comforting, because on the
Yes.
days that I do feel like,
You feel
dang, am I
alone.
the only
Yeah.
person that feels
Yes.
this? Am I the one that's going crazy? I just remember,
Yes.
no, I'm not. And I have a lot of really cool and awesome and smart and dedicated people beside me and
Yes.
behind me and in front of me leading me. And it just feels good.
Yes.
All right, you guys, we'll stop our love fest. But Sarah, seriously, thank you so much for being here. Thanks for
Oh, thank
sharing all your
you.
wisdom. If people wanted to follow along with you or learn from you, how can they connect with you, and where do they find you?
I am on, oh gosh, I'm on TikTok, Facebook, and Instagram, and I am Labor Junkie RN. And my name is Sarah. Nobody knows my name. That's my name.
Labor Junkie RN. You are in my phone as Labor Junkie RN,
Yes.
Sarah, but yeah, I don't think I'll ever change that. I love it when that pops
That's
up on
fine
my
with
screen.
me.
Thank you so much for being here. And listeners, you
Oh,
can connect with me on Instagram or TikTok at Tranquility by Hihi, and check out the Birth Lounge membership for more information on how to have an informed and confident birth. I will see you next episode. Bye, y'all. Thank you so much for tuning in today. I truly do value this community and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by Hihi on all platforms. Until next time, stay educated, stay supported, stay confident. Bye!